Okay, so for today, we're going to wrap up our psychological disorders from last week. And the first disorder that we're going to talk about today is schizophrenia. Those who experience schizophrenia are experiencing something that's called a mental split from reality and rationality. Now, schizophrenia actually means split mind. That's the definition of it. And people get confused and think that that means that it's a split personality, which is not true. That's a completely different disorder. So the person who has this split mind, as schizophrenics do, they tend to be people that uh, act inappropriately during certain situations. So it's like the reality of the situation does not match their emotional response to the situation. So there's positive and negative symptoms related to schizophrenia. The positive symptoms would be those that are the presence of problematic behaviors, so adding something that's not good. And then the negative would be the absence of healthy behaviors. So there's a lot of different types of schizophrenia, but for this course, being as its intro, we're just going to talk about schizophrenia in a very broad manner. So the first part here is this presence of positive symptoms that are problematic. Hallucinations, especially auditory. So in other words, they actually hear voices in their minds, in their heads. Delusions. Um, these are often really bizarre, and most common are delusions of grandeur or persecution. So either they think that they're just the most wonderful person on the planet, or everybody is kind of out to get them. They have disorganized thought and nonsensical speech, and we often refer to this as word salad. So they just start talking and putting words together that make literally no sense at all. And then the bizarre behaviors that may go along with this, and these could be any kind of behaviors that you can imagine. The negative side here is this absence of healthy behaviors. So the flat affect is probably one of the easiest things to spot. And this would occur, for example, if maybe the person went to a surprise birthday party and everybody jumped out, they just wouldn't respond. Or sometimes if they may go to a funeral, for example, they may not show any emotion on their face and have no real emotional response to it. Or they could have these very odd and socially inappropriate behaviors, or they might laugh or crack jokes at the funeral because they have this inability to read others and an inability to understand how to act emotionally in any kind of situation. Next, we're going to look at dissociative disorders. So this refers to a separation from what's occurring in our conscious lives. We're separated from our thoughts, a memory, maybe even bodily sensations, feelings, or even from knowing who we are. So a dissociative disorder refers to a dysfunction and distress caused by this chronic and severe dissociation with ourselves. So the first type is your amnesia. This is a loss of memory with no known physical cause. So these people are just completely unable to recall any kind of memories. A lot of times these memories may be associated with trauma. So, or at least that's what they will tell you. So they may have gone through some kind of traumatic event and have no memory of it, or it could be a car accident, and they can't tell you what was happening 5 minutes before they got into that accident. They've completely lost this ability. The next type is your fugue. So dissociative fugue. And this is where it's kind of an interesting one. You don't really see it very often, but it's as though something so stressful in life causes a person to just run away. They literally just take off. Now, this could last for hours, it could last for days, and they have no memory of their life, their identity. And usually these people can be found, somewhere wandering around the streets. They might be picked up by the police, and then when they're questioned, they just have no clue where they came from. This one in particular is quite rare. The final one is the most argued about amongst researchers. That's your dissociative identity disorder, otherwise known as DID, and previously known as multiple personality disorder. So this is where people will actually develop several different types of personalities. And this development of personalities is believed to stem from some kind of childhood trauma, usually sexual abuse in some kind of way. So for the next slide, I want you to watch this video and then we'll fill in that blank. Okay, so hopefully you've watched the video here, and what we're going to look at is whether or not there's evidence that will support DID. Now, as I told you before, a lot of people felt that this did not exist, this disorder. And it's probably due to the fact that people have indeed faked it. And there are cited cases that do show that people have faked having multiple personalities for several different reasons. A lot of them have to do with getting out of some kind of crime and not being convicted and going for an insanity plea. However, there is some evidence that does support the existence of multiple personalities, or DID. The first one here is the one that was mentioned in the video, which is that when these different personalities come out, we actually see different brainwave patterns. So number one, there are different brainwave patterns depending on the personality that comes out. Number two, we also notice in some people in particular that they have different left-right handedness. Different left-right handedness. And number three, which is probably the most interesting and easily the one that's hardest to control, is that these different personalities actually will show different visual acuity and eye muscle balance patterns. Right? So how do you control the muscles in your eyes? That's pretty difficult to do. So I would say that there's a good amount of evidence here that supports multiple personalities, or DID, but one of the major problems with it is that a lot of people have faked it over the years, and that's kind of thrown a wrench in it for others. Okay, so we're moving on to talking about eating disorders. For the most part, eating disorders involve an unrealistic body image and extreme body ideal, a desire to control food and the body when one situation can't be controlled. Generally, they're hallmarked by depression and health problems. So the two we're going to talk about today are anorexia and bulimia. So for those who are anorexic, these people tend to have a great compulsion to work out as much as possible, and they always tend to see themselves as being fat, even though they're extremely underweight. For those who have bulimia, these people have a compulsion to binge, so they'll eat thousands of calories at once, and then they'll purge by losing the food in some kind of way. So the purging may be via vomiting, or it may be via laxatives, but they try to purge the food out. In general, what we see is that those who have anorexia are much more easy to spot because they're so incredibly thin. But those who have bulimia tend to look kind of normal, and so it's much more difficult to diagnose and spot bulimics. And so bulimics tend to go on for longer in lifetime than the anorexics do. Okay, so when we're talking about these disorders, we want to know what contributes to them. So there are a couple of family factors. The first one, unfortunately, does fall on the mother. So when we're talking about these eating disorders, we are focusing more on women than men, although they do exist in men as well. So for the first one, number one here, it's having a mother focused on her weight. So how she looks. So this means the daughter or son is growing up watching mom obsess about her own looks or complaining about how heavy she is or how she doesn't look good. The second one here is a mother, or a father too, that's focused on the child's appearance and weight. Okay, so first they're focused on themselves. I don't look good enough. I'm not skinny enough. And then they turn to their child and basically do the same thing. So that's 1 and 2. Now, number 3 here, for anorexia, what we see is that those who come with anorexia tend to come from families that are very competitive, very high achieving, and very protective of their kids. They're very controlling of their kids. Uh, Mostly what we see is for anorexics is that they're coming from upper middle class families that tend to be white. Number 4, for bulimia, normally we see this occurring amongst families that tend to have a lot of obesity. So these are kids that are growing up looking around them and seeing that their brothers or sisters are heavy, their parents are overweight, and this is much more likely to cause bulimia in that child in hopes of trying to change that pattern, that family pattern. And then finally, we have this unrealistic ideal of body appearance, and that's a cultural factor. So this final point here, it's a cultural factor. So next we're going to talk about childhood disorders. The first one is autism. Autism is something that appears usually pretty early in childhood. Most kids, you can usually diagnose them by ages 2 or 3 years old, and the parents notice this much earlier. So by about the first year, parents are noticing that their child does not seem to communicate, doesn't seem to enjoy social interaction, and certainly doesn't seem to be connecting with other people. Nowadays, the DSM, which is the Diagnostic Statistical Manual that we use to diagnose people with these disorders, has now put autism on a spectrum. So on one end of the spectrum is autism, and on the other end is Asperger's. So a very mild form of autism would be considered Asperger's, and these people just have a little bit of a more difficult time connecting with others or understanding other people's emotions, but otherwise you can't really detect any difference. Maybe just slightly a little bit odd, but for the most part they fit into society and they have relationships and they have jobs and as well. For those on the other end of the spectrum that are actually autistic, this can become quite severe, and for those who are severely autistic, it's unlikely they'll get a full-time job ever at any point. It's unlikely they'll get married, and they tend to have a much harder time holding down relationships. The next one is attention deficit hyperactivity disorder, or otherwise known as ADHD. So ADHD involves a child that tends to be very impulsive, overactive, and sometimes they have this very disruptive behavior. We try nowadays to not diagnose kids with ADHD until at least 7 or maybe 8 years old. Although you can see these behaviors occurring earlier on, as early as 3 and 4 and 5, it's recommended not to diagnose kids that soon, and especially recommended not to start medicating kids that early on. So we try to hold back on that diagnosis. In particular, ADHD is a diagnosis that is usually given to boys. And what we find is that for a lot of boys, especially around the ages of 4 and 5, they tend to be very hyperactive, and they look a little bit like they may have ADHD. However, they tend to settle down by the time they hit 7 or 8, which is why we wait for that diagnosis. So for some boys, they don't settle down. They keep up with that hyperactivity. And then we know maybe there's a problem here. And the first thing that we'll do is try to address it with therapy. And the last thing that we'll do is medicate the child. Okay, so now we're going to move on to talking about therapy. In general, there are two current forms of therapy. The first one is psychotherapy, and the second one is biomedical therapy. So, the psychotherapy is this interactive experience that you're going to have with a trained professional who's going to work on understanding and changing your behaviors, your thinking, your relationships, and or your emotions. Biomedical therapy is a little bit more detached from the person and uses medications and other procedures to act directly on the body to reduce these symptoms that may cause mental disorders. In general, what we find today is that most therapists use this eclectic approach, which applies all these various forms or techniques. So you may find if you've had any kind of mental problems in the past or psychological disorders that you will be required to take therapy or do therapy in addition to your medications. So for today, we're going to talk about 4 noteworthy schools of psychotherapy. The first one is the traditional one, which is psychoanalysis, and this was championed by Sigmund Freud, and his legacy is carried on today. And it's literally what you picture probably in your mind when you think about therapy. Going into a room, laying down on a couch while the therapist sits out of view, and basically discussing your childhood. The second type is the humanistic approach, and these humanistics prefer that the people that they serve are called clients and not patients. So it's called client-centered therapy, and this is a therapy that really works on you discovering yourself and you self-actualizing and becoming your best self. Next is behavioral therapy, and this is usually applied when we're trying to get over some kind of phobia that we may have or some kind of bad habit, such as biting your fingernails. And then finally, there's cognitive therapy, and this is often used for people that suffer from depression. And the idea here is to change the way that you think and perceive the world around you so that you don't see it in such a negative light. So we're going to go through each one of these. So first off is psychoanalysis. Um, with this type of therapy, it's again referring to the set of techniques for releasing some kind of tension or repression and unresolved conflict that may be within you. Usually it's tied into some kind of early childhood experiences, most likely with your parents. The idea here with psychoanalysis is to say that anything that's basically wrong with you must stem from your early childhood experiences, and especially those with your parents. The techniques used in this type of therapy are meant to bring out these repressed feelings that you may have for your mother or father. And 2 techniques that are used are free association and interpretation. So the free association is where this is your typical idea where you would sit down on a couch or lay down on a couch and just start talking about anything. And as the patient begins speaking, it seems like they tend to themselves uncover their own problems. They start to speak very freely about any kind of memories or dreams or feelings they may have had about their childhood. Now, it's the therapist's job to interpret exactly what's going on underneath what the person is saying. So they're trying to, as they're listening to you, they're trying to figure out what's really tapping into your unconscious wishes and meanings, and in hopes of giving you some kind of insight that will help you understand where your conflict or your inner conflict lies. And by just understanding that, it should release the tension, and you'll be cured. So this is why it's called the talking cure. So I've attached a little bit of, if you see here, there's a link that you can watch that gives you a little bit more information about psychoanalysis. So the job of the therapist in psychoanalysis is to really try to uncover your unconscious and try to understand what you really are getting at by what you're saying. And they do this in 3 ways. They look at your resistance, your dreams, and how much you transfer your feelings onto them. So resistance means that, let's say that you're talking about your past, your childhood, and you spend a lot of time talking about your mother, but you never talk about your father. Well, the therapist would note that, and they would call that resistance. And they may feel that it's possible that you have some kind of bad feelings toward your father, and that's why you never bring him up or talk about him in therapy. They also look at your dreams. So as we talked about before, they're going to be very interested in the latent content of your dream. So not literally what happened, but what it means. There has been a little bit of research on this, and what we find is that some of these dreams, like the dreams of falling or your dreams of being chased or somebody's trying to get you or kill you, usually do tie in with anxiety. So that would be the latent content. So let's say that you're being chased by somebody with a knife. They're not. That's the manifest content. But why are you being chased by somebody with a knife? That's the question here. That taps into the latent content, and we think that it means that you have a lot of anxiety. So maybe you need to do a lot of things in your life. This is very common. These types of dreams of being chased are really common among college students because they're under so much pressure and stress to do really well, and they have a lot of classes, and a lot of them are working as well, and several have kids too, and so they have a lot of stress, and they feel a lot of anxiety. And then the last one is transference. So this means the patient may have some kind of reaction toward the therapist that is actually based on feelings toward somebody in the past. This happened often with Freud, so if you watch the video, you'll see that Freud's patients often fell in love with him because they were, I guess the idea here is that a lot of these women were maybe kind of had sexual feelings toward their father, and they saw Freud as being a father figure type. And here's your final example of a therapist. This one is a funny, humorous example, but I think it's pretty good. And I just happen to like the show a lot, so that's why I clipped it in here. So go ahead and watch that. Next is client-centered therapy. And you'll see here again, I have an example video that you can watch. But the idea of the client-centered therapist is that they're very non-directive. So they let insight and goals come from the client rather than trying to interpret what the client is really meaning. They want to be very genuine. They want you to be genuine. They want you to be yourself. And as a therapist, they don't put on any kind of facade. So this genuine thing is a two-way street. They tend to be very accepting, and they will always show you unconditional positive regard. So this means you may end up telling the therapist some negative things about yourself, or things that you did to hurt or harm others, or even society. No matter what you say, it's the therapist's job to always give you unconditional positive regard and always act very, very empathetic. So this is demonstrating a very careful attention to the client's feelings, partly by reflecting what they hear the client saying. So funny enough, when I was an undergrad at the University of Minnesota, I worked at a suicide hotline, and they spent literally 3 months training me to do this type of therapy. And the only thing that I was trained to do for 3 solid months was active listening. So, in other words, I would have to listen to the person on the other end of the phone, and I would summarize. They would tell me something that happened. I got into a giant fight with my partner, and this is what happened. My response would be to summarize what they said to me or paraphrase it, right? And then feed that back to them and invite any kind of clarification. So I would say something like, "Oh, so I understand that you are having a fight with your partner. Is that correct?" And that kind of invites clarification and elaboration. And they'll say, "Yes, this is what happened again." And then I'll say, "It sounds like you feel very angry or very frustrated." So I'm reflecting their feelings in some kind of way. And this goes back and forth, back and forth. It feels very uncomfortable as a therapist to do this because you're not allowed to give any opinion on your own. You're just feeding them back their own thoughts. You're literally a sounding board in this type of therapy. Behavior therapy uses the principles of learning, especially classical and operant conditioning, to help reduce unwanted responses. These might include behaviors like addictions or emotions such as panic. A lot of times, counter conditioning will be used, which refers to linking a new positive response to a previously aversive stimuli, or linking undesirable behaviors with aversive stimuli. One example of behavior therapy is called exposure therapy. So sometimes exposure therapy is used to help people get over situations that they have unrealistic fears about. So in these cases, they'll either use systematic desensitization, which is beginning with a very tiny reminder of the feared situation and then increasing that exposure of intensity as the person learns to tolerate the previous level. So let's say that you have a fear of snakes. At first, the therapist would just show you pictures of snakes, and then eventually maybe a video of a snake. And then maybe they would bring a snake in a cage into the room, and lastly, they might bring a snake for you to even hold. Virtual reality therapy involves exposure to simulations, such as flying. And this is often used for people that are fearful of flying. So they come into the lab and they put this mask on, and they are exposed to what feels like being on a plane. And the more exposure they get to this, the better off they are when they actually do have to fly. Aversive conditioning is a type of counterconditioning that associates an unpleasant state, such as getting sick, with an unwanted behavior, such as drinking alcohol. So this is often used, if you think about, there's a lot of different ways of going about this, but today probably the most popular way is through different types of drugs that make you sick when you drink alcohol. So this is used for patients that are in rehab and trying to get over alcohol. They will take this drug called Antabuse, and if they take it in the morning and have even a sip of alcohol, they'll get very, very, very ill. So what happens here is that the alcohol itself gets associated with being ill, and eventually if you take away the drug, you'll always feel ill when you see alcohol and you won't drink it. So cognitive therapies really focus a lot on changing your perspective about life. So here's an example. Let's say that you lose your job. Now, if you have some kind of a certain type of perspective, you may tell yourself that you're worthless and that it's hopeless to even try again. And that might lead you to depression. However, cognitive therapists try to change that middle box there. They try to make you realize maybe it's not you. And what if you make different attributions? So let's say again you lose your job, but this time you don't blame yourself. Instead, you blame your boss. Your boss is a jerk, and you realize you're too good for the company anyway, and you may as well move on. And this will lead to no depression. So you'll see that I have a little video clip here that you can watch that will explain cognitive therapy in a different kind of way, but it's really just about changing your perceptions of other people and your perception of your life. So cognitive therapy is really concerned with helping people see how their problems are actually worsened by the way that they think about them. For example, we will catastrophize the things that happen to us. So maybe you say to yourself, wow, I did really poorly on Esther's first exam. Now I failed this class, so I give up. Right? So just going a little bit overboard. They'll have selective abstraction and magnification. So this means that you may have an interaction with somebody that goes really, really well, but there was one awkward moment. And so when you walk away from that interaction, the only thing that you think about is that one tiny awkward moment, and you focus on that. Next is minimization. So when something really positive does happen to you in your life, you still tend to make that event much less important than it really is. And then finally, automatic thoughts. So these are notions or ideas that occur without any kind of effort or choice on your part, and they're usually distorted, and they can lead to very quick emotional responses. Our automatic thoughts are something that we've worked on over the years. So maybe let's say that you are dealing, I'm just going to pick a good example here. Maybe you have in-laws, right? And you have a mother-in-law, for example. And a couple of times in your life, she has done things that you felt were manipulative or against what you wanted from her. You begin to think badly about her. And your mind, every time you think about her, goes right into those bad feelings. So the next time she does something that's ambiguous in some kind of way, maybe not threatening toward you, but just could have been, you immediately have these automatic thoughts that tell you, ah, I knew it, she's out to get me, she's a bad person. And we'll do that with a lot of people. We'll do that with friends, we'll do that with professors, we'll do that with our loved ones, we'll do that with our partners. So the therapist's job here is to try and challenge these thoughts, these automatic thoughts, and all the other things that we do in order for us to feel less um, upset about life and less depressed about life. All right, so next we're going to talk about these three different types of therapies. The first one is family therapy. This therapy is typically used when couples are having marital problems and also used when a young child is having problems. So the entire family generally comes to the therapy session and the whole family is involved. The idea here is that kids can't fully understand the cognitive aspects of the therapy, but their parents can. So the therapist kind of works with the parents to help the child. Next is your group therapy. And usually this is going to be about 6 to 9 people, and they have some kind of problem that they can all relate to. Oftentimes, group therapy occurs when people are victims of tremendous trauma. So maybe they went through 9/11 together, or Hurricane Katrina, or some kind of other natural disaster. They may all be victims of violence in some kind of way. So maybe they had been involved in some kind of domestic violence, or they lost a child to violence, or these may be people that all share the same type of cancer. The idea here with group therapy is that being around other people that are going through the same thing as you will make you feel better and make you feel like you are not alone. Last is your self-help groups. Now, these are the groups that don't have a therapist. So group therapy and family therapy are both led by therapists, but self-help groups are not led by therapists at all. They're actually led by the group members. So again, everybody in the group shares some kind of similar problem, right? And they all want to get over this problem, and they focus on supporting each other rather than on working on goals during any kind of group session. They just want to interact and make these connections. Probably the most famous self-help group in the United States would be Alcoholics Anonymous. So for the next few slides, I'm just giving you a pretty good list of different types of medication therapies, otherwise known as psychopharmacology, which refers to the study of drug effects on the behavior, the mood, and the mind. So I'm not going to go through each one of these lists, but I recommend that you keep them close to you for exam number 3. Next, we have electroconvulsive therapy, otherwise known as ECT. This therapy is only used if everything else has been exhausted. So in general, this is the kind of therapy, it's shock therapy, as you may have heard of it. It's usually used for people that have severe depression and nothing else works, or people that have seizures and nothing else works. The interesting thing to note about this, and this will come up on the exam, is that shock therapy works, but nobody knows why or how it works. Okay, and now we're on to the last slide of the course, which is psychosurgery. Back in the 1930s, it was discovered that cutting the nerves connecting the frontal lobes to the emotion centers of the inner brain tended to calm uncontrollable and violent patients, and also seemed to help those who had depression. It only took about 10 minutes. So a neurosurgeon would actually shock a patient into a coma and then literally ram ice picks through the eye sockets and then wiggle them around. That would sever connections to the frontal lobes. By 1950, about 35,000 people in this country had lobotomies. Now, we stopped doing lobotomies because Rosemary Kennedy was probably the poster child for what a botched lobotomy looked like. Now, other than being a little bit uncontrollable and a little bit violent, she was relatively normal and could function in society. But after her lobotomy, she was completely unable to function whatsoever in any way, shape, or form. So lobotomy stopped happening in this country when calming drugs became more available. Today, over here, microsurgery is used only in very extreme cases where the patient is suffering from seizures or extreme OCD. But it's rarely used, and once it's done, it's irreversible. So microsurgery is kind of like a lobotomy, but just like a very, very small portion of the brain is affected. And that's it.